Good afternoon. We hope everybody enjoyed their cookie and coffee break and are settled in for the second half of our symposium today. My name is Yaya Wu. I'm a second-year law student at the University of Pennsylvania, and I'm a Toll Public Interest Scholar. I'm honored to present the panelists of Poverty's Youngest Victims, Ethical Choices for First Responders and Advocates in the Fight for Healthy and Affordable Food. Collectively, these panelists bring decades of hunger advocacy to the table. They have worked in a variety of fields, from legal services to policy organizations to healthcare, and engaged in a variety of endeavors from political advocacy to academia to research. Two ties hold this group together. First, their unrivaled dedication to feeding America's children, and second, their willingness to engage in and dialogue about the transformation of the vision of advocacy within the child hunger realm. Child hunger has been at the forefront of cross-sector collaboration, and I am confident that the ethical and practical lessons they will share today will be insightful to everyone who seeks to aid in the war against poverty. So sitting from, I guess, your left to right are, your right to left are Dr. Mariana Chilton, an Associate Professor of Public Health at the Drexel University School of Public Health and co-founder of Witnesses to Hunger. Professor David Super, a professor of law at the University of Maryland and starting next year at Georgetown Law. Dr. Kathleen Conroy, a primary care pediatrician at Children's Hospital in Boston and medical director of the Medical Legal Partnership in the Children's Hospital. And Jonathan Stein, general counsel of Philadelphia's own Community Legal Services. Mr. Stein's work was instrumental in creating Philadelphia's free school meals program. To frame the conversation, let us begin with a video presentation.
Tired of eating for products. We gotta take us more to our love. my carry can full. This is what I'll have for supper.
We can end hunger in our nation in months. We certainly have the money.
This is about sincere legislative change. How bad does it really have to be before we pay attention to it?
That was a trailer from a documentary called Hungry in America. It is slated to open sometime this winter. So let's begin with Dr. Mariana Chilton. Please tell us a little bit more about this project and the stories that inspired it.
Okay. I'll just give you a brief explanation of what Witnesses to Hunger is, and then I'll talk about the magnitude of hunger in America and why we've taken this particular approach. Witnesses to Hunger, which is one of the many things that is featured in this film, is a project that started out of the emergency room at St. Christopher's Hospital for Children in 2008. And at St. Christopher's Hospital, I'm doing ongoing research. I'm a professor of public health at Drexel University, and we do research. I'm a part of a multi-site study called Children's Health Watch. And in Children's Health Watch, we're looking at the impact of public policies on the health and well-being of very young children under the age of 3. So what we do is we look at the participation rates in food stamps, now called SNAP, or WIC, or LIHEAP, child care subsidies, et cetera, and we can see how those are related to food insecurity or hunger rates, child development, and maternal depressive symptoms. And then what we do is we translate those, our results, not only for a peer-reviewed publication, but we translate them into policy briefs and bring that to the Hill, and we try to testify before Congress as much as we can to talk about the importance of food stamps, the importance of WIC for child development. We try to show how LIHEAP, which is the Low Income Home and Energy Assistance Program, how important LIHEAP is for child health, that LIHEAP is actually a public health program for young children. It happened that I had just finished giving a testimony for the Farm Bill, and I was very disappointed in the response of the people in the House of Representatives and of their total lack of understanding of what was going on. And on the Hill, we're called an expert witness, right, because we're doctors, the white coat type of people. But it struck me as absolutely unacceptable and unethical that I would be called an expert witness when, yes, I do witness hunger in the emergency room at St. Christopher's Hospital. I have witnessed it among the families in Philadelphia with whom I work. I've volunteered at multiple food pantries around the city and have gotten to know many women throughout the city and have seen their pain and help them to try to get services. It is unacceptable for me to be there as an expert witness when you have a person who is hungry and or homeless that is the true expert that is completely disregarded in the national dialogue on hunger in America. So I launched Witnesses to Hunger a little bit out of frustration. So Witnesses to Hunger is it's a photo voice, it's a photo advocacy type of project. It's also a research project where I gave 42 women in Philadelphia a camera. Each of them had their own camera, and I asked them to take pictures of what it was like for them to raise their children in poverty in order to teach the public, the press, and the policymakers about their experiences with hunger and their experiences with the welfare assistance programs, and to talk about their ideas for change, talk about what they wanted to have to be different, what they wanted us to do. So it's not about voyeurism, let's just talk about how terrible things are and be done with it. It's about, let me teach you as an expert on what it's like for me and for my children, and this is, I want to teach you what you need to do. So it's about social action. The exhibit has shown in the exhibit of their photographs. We have over 10,000 photographs, but we have an exhibit that travels around the country. It's shown in Philadelphia several times. It was invited to the Senate Rotunda by Senator Casey in 2009, gearing up for the child nutrition reauthorization, which I'm sure we'll talk about more. And then Senator Casey helped us to bring it around the state of Pennsylvania to raise awareness about hunger and poverty and to have to recruit new witnesses across the state. And we are also now recruiting new witnesses in Boston, Baltimore, and in Camden to join the Witnesses to Hunger program so that women in various communities can actually talk about their own local issues and do it in the way that they would like to do from their own kitchens, from their own living rooms, and bring those to the State House, to their City Hall, to wherever they want to go. And if they would like to work with the Witnesses to Hunger in Philadelphia, we will support them through technical assistance. So it's an exciting project because one of the most important things about Witnesses is that it is trying to cut through indifference. And it is trying to bring to light the experience of hunger, which is generally muffled. It's hidden by those who are experiencing it, and it's hidden from the people. People actively deny that hunger is a problem in this country. And I just would like to talk to you about the magnitude of hunger in America. The numbers in the trailer that you just saw, where it said that there were 38 million people in America that were food insecure, that number has now risen to 49 million. It's 14% of the general U.S. population. It said in the trailer it was 14 million of that 38 million was children. It's now up to 17 million children due to the recession. And it's most important that you think about the very young children, the children who are 5 years old and younger. The rates of food insecurity in this country are 1 in 4. That's 9 million infants and toddlers, preschoolers, and some kindergartners that are living in households where they don't have enough money for food. So I use this term food insecurity, which is sort of this broad term that those of us who do research on hunger have tried to get the general public to understand very unsuccessfully, so I'll explain it to you. Food insecurity is the lack of access to enough food for an active and healthy life. In other words, families don't have enough money for food, they're not healthy, they eat a lot of poor quality foods, may not eat for a whole day, may live off of oodles of noodles for a week, and then eat well for 3 weeks. That is the experience of food insecurity. And in our research, what we show is that food insecurity is very much related to poor child development, increased hospitalization rates, maternal depressive symptoms, and the list goes on. There are 2 things holding us back from addressing hunger in America, and this is what Witnesses is working on trying to cut through. The first one is a misperception that hunger does not exist. I've already explained to you that it does. So how can we cut through the denial? And how can we get the people who are hungry to be able to speak out, to stop hiding it, and to tell us what they need us to do? The second problem is that there's major conceptual confusion about hunger in America. That people think that you can see hunger, that you can see a kid fishing around in the garbage can and then therefore that child is hungry. But you can't really see it. Where you see it is in the emergency rooms, we see it in our clinics, and you all see it in your legal offices under the guise of domestic violence, homelessness, slumlords, the list goes on. Researchers have continued, the USDA and us researchers have contributed to this misperception. We call it food insecurity. People can't understand the concept. Then we don't want to use the word hunger because it's not really hunger. I hope we can talk about this misperception in our dialogue, but it's something that's really important, and that's why I felt like it was so important to get the women in Philadelphia with whom I work to take photographs that cut straight through your intellect and goes straight to, or deals on a different level about what that experience is like, to have them define it and describe it for the rest of us. Finally, I want to make one last point about how hunger is really an experience of entitlement failure. It's not about lack of food. It's about not having access to basic human needs. There is no family that's going hungry that doesn't also have a problem with housing, stable and affordable housing, and being able to pay their utility bills. The list goes on. But those are the 3 main things: energy, housing, and food. They go hand in hand. And if they're not hungry for that particular month, they may not be able to pay their rent, or they may be living without running water, without electricity. So I'm sure the other panelists will pick up on that. We have the research to back it up. And that's where the lawyers come in, and that's why this type of intersectionality, this type of working together is extremely important, where you have public health, you have the advocates, and you have lawyers working together to address the problem.
Thank you. Now, Professor Super, are there federal and state governments sufficiently responding to this need? And in your opinion, how has their action plan changed the role of advocates today?
Sadly, the federal state governments are falling way short of this, and that's why you have the disturbing statistics and even more disturbing human effects that Mariana's just described. I would start by emphatically agreeing with her that hunger is a problem that defies isolation, where our panel is about hungry children, but in fact, you generally have hungry households, and there are big consequences for the children when the parents are hungry, and so that it requires a holistic approach from the family perspective, and also a holistic approach in terms of the particular problems that exist. A number of doctors have done wonderful research showing that when families are spending high fractions of their income on heating bills, that incidence of hunger and diet-related problems skyrocket. Similarly, children that don't have sufficient nutrient intake are more vulnerable to lead poisoning, which is thought of as technically a health issue, that these lines are not useful, and in fact, that the problems need to be understood in a much more holistic way. In terms of the federal and state response to this, the record is mixed. The so-called stimulus law, ARA, that was passed in early 2009, did include modest improvements to the SNAP program, what used to be known as food stamps, and because the SNAP program does have open-ended funding to meet the needs of anyone that qualifies for the program, it has increased its participation enormously. By contrast, in about half the states, welfare participation has been flat or even declining in this time of skyrocketing poverty and need. So in those senses, SNAP and our food programs have made important contributions, but they still face very serious problems. The states are understaffed. They've been going through budget crises and have been laying off or allowing attrition in their staff at the very time the number of people coming to them for assistance has been going way up. We provided a little bit of extra money for them in the stimulus bill, but we didn't renew it. That money's now gone. And states are their administration is not keeping up with people applying, so there are many people that are applying that are having to wait for very long times, far longer than the law allows, to get assistance. There also are tens of thousands, at least, probably hundreds of thousands of households that remain eligible for assistance but are being arbitrarily cut off because the state doesn't have the staff to do the paperwork to keep them on the program. There are vulnerable groups that are, I think, among those most in need and that are not the people that advocates, legal services programs, and others have been as accustomed to serving or that are commonly understood as being the most vulnerable. One group is the new poor, people who probably weren't doing all that well before but had some sort of a job and weren't on these programs, are now needing assistance from things like SNAP, may not be familiar with its rules or how to access it, and may not be familiar with the availability of legal services, and are not getting served when they have trouble accessing it. They also are going to be among those that are going to be most confused when the states, the understaffed states, mishandle their cases or just don't handle their cases because they don't have the resources to do it. Another group of highly vulnerable people are those that are technologically or bureaucratically challenged, or simply that have limited literacy. In the first panel this morning, we were told about the high incidence of illiteracy or marginal literacy among people reentering from the criminal justice system. That's true in a much broader swath of the population, and as states are eliminating paper applications, are using electronic online applications, that often have a graduate school reading level and are making people, I guess some states are now moving to making people interact almost entirely online with the system. Many of the people who are not having trouble finding jobs because of skills limitations, those very same limitations that put them in need, are also putting them in a position where they can't access these programs. And again, there's a great deal of stigma and shame that goes with this, and these may not be the first people that come forward, unfortunately, and talk about their concern. This calls, I think, for an expansion of or a change in our approach to advocacy affecting lawyers and other people that work with the low-income community together. That the model of resolving willful disputes. When I was a legal services lawyer in North Philadelphia, the state would deny my clients food stamps because it thought they were ineligible, and we would take an administrative proceeding or sue them or whatever and duke it out in the more traditional lawyer-like role. What's happening now are people are getting dropped from the program not because anyone thinks they're ineligible, but because the state computer system isn't working or because the state doesn't have the staff to process their application for redetermination. It's not willful denials, but it's denials that have dramatic effects on families nonetheless. This needs to become a broader, a greater emphasis of focus. And in addition, to serve people who may be getting left out for technological or bureaucratic reasons, and to serve people that are new to these programs, may not know they exist, or may have only a very dim understanding of them. Advocates need to get clients from new sources, from people that may see them. And certainly healthcare providers is an obvious place where the consequences of hunger are going to be seen, and working closely with healthcare providers, I think, is a pivotal way of getting clients. They're certainly in the world of professional ethics, there are strong duties that apply and that need to apply to how lawyers handle clients once they've taken them on board. Those rules are generally fairly quiet about how lawyers choose their clients or how that attorney-client relationship, decisions made to form that relationship in the first place. And I would suggest that lawyers, in face of these new challenges, need to think more broadly about which sorts of representation can most benefit the broader community, and should see themselves in collaboration with community groups, client groups, as trustees for a finite and grossly insufficient pool of resources for advocacy in this area to take on some of these problems with the understaffing of state agencies and bureaucratic disentitlement. Thank you.
Thank you, Dr. Conroy. Dr. Conroy, please tell us what roles doctors in the medical-legal partnership play in the fight against hunger, and what have you found to be the successes and challenges of such a cross-sector collaboration? And I will pull up your PowerPoint.
And thank you to David for the lead-in. I like that doctors are considered a good resource in this area. I wanted to really quickly frame my approach to hunger and then talk a little bit about a program called Medical Legal Partnership, which some of you may be familiar with. So as Yaya said at the beginning, I'm a pediatrician at Children's Hospital Boston, straying into enemy territory by coming this close to Children's Hospital of Philadelphia, but I was willing to take the risk. And so I think for me, this cartoon really sums up a lot about what it's like to practice in a low-income community. And my practice is indeed that. And so there's sort of this idea that you know that the medicine that you're looking at is really the tip of the iceberg, and that in fact the families are working with a large variety of stressful problems, which are not only crowding out space for them, but are obviously highly related to the medicine you're seeing. So we know that these same issues that this mother is sweating it out with here are actually causing health problems and then vastly complicating the care that we're also trying to give. So that's a given. I don't need to tell you that. And we see this in our clinic. This was a study, very dry slide, I apologize, done in our clinic in 2006, where we asked, sorry, this is not my study, but where the doctor who was doing the study asked folks in the waiting room about their health-related social problems, that's the RSP. So the black bars are what percentage of folks have the problem. The slanted gray bars are what percentage of folks say that they were asked about that problem by their provider within the last year. And then the white bars are how willing was the individual to talk about this with their doctor. And you can see for, they call it food security, it should be food insecurity, that 39% of the folks in our clinic waiting room endorsed food insecurity. Only 17% had said they'd been asked about it by a provider in the last year. This in the face of what David just referred to as healthcare providers potentially being a good link-in point for many existing services for which people are eligible. And whereas the willingness to talk about this with a provider was not in any way universal, but was actually quite high. And this is pretty well-known stuff. It's been looked at in many different ways. Folks are willing to talk about it. Doctors aren't talking about it. Resources exist that we're not tapping into. But I think, and I apologize if the slide got really ugly when I transferred from Mac to PC, but and this is actually data that was done by Dr. Chilton's group, which again is a multi-site study. And actually, part of the data is and part of the data isn't. But the point of this slide, and I think the point that we each keep coming back to, is the idea that food insecurity never exists alone. In fact, it's often the final common pathway of a variety of other social risk factors. And so we know that housing is an issue we focus on a lot in Boston because our housing costs are even higher than yours here in Philly. But this is a very common Northeastern problem, right? The cost of housing is crowding out the cost of paying for other basic needs in the budget. And we all understand this from our own budgets. Housing affordability is supposed to be capped at 30% of a family's income, as you guys all know, being folks interested in these issues, and that folks who are paying over 50% of their income on housing are therefore extremely housing insecure. And so for folks in this situation who are also low income, they spend 30% less on food and 70% less on healthcare than they would, than their compatriots who make the same amount of money but are not spending as much on their housing. So this has very direct health effects, even before you consider the health effects of the probably pretty unsanitary housing conditions that people are living in, even for that much money. And the other data that does actually come out of Dr. Chilton's group looked at folks who were on the waiting list for housing subsidies versus folks who were not on the waiting list for housing subsidies. And we're able to show that folks who were on the waiting list, so not getting the subsidy, had 2 to 3 times higher rates of stunting in their children. And to understand that, you have to know that stunting is the sort of the end product of chronic nutrition. So when kids get deprived of calories, they get first skinny and then they get permanent loss of linear height. So for these kids, we're actually in this country, again, this sort of very shocking example of true hunger, that kids are having permanent loss of growth. In this case, partially because their housing wasn't subsidized, so their families were taking such a hit out of the food budget. So just to say that all of these issues are interrelated, and whenever we're approaching these from the medical setting or wherever you're approaching them from the legal setting, they're obviously all happening at the same time for a family. So obviously, we have a long tradition in medicine of involving social work in our clinics, and I will never underestimate the importance of social work. But what we find is that doctors who are working as advocates and social workers who are working in clinical settings actually face the same legal barriers as the patients themselves when those legal barriers arise, right? We're not actually all that sophisticated when it comes to advocating for patients when, in fact, there's actually a real legal need. And so over time, what has happened is in our group, Medical Legal Partnership, which I'll tell you a little bit more about, is we began to realize that with every social need, there's a subset of that social need that is truly a legal need, which again, I don't need to tell this crowd, but I think it's been a very helpful point in educating doctors that when you have food insecurity, some of what the family needs are social interventions, perhaps their first-time food stamp application, perhaps they need a referral to WIC. But in the face of unfair denial of food stamps or miscalculation of food stamps, actually neither a social worker nor a doctor is actually going to be very effective in that situation in helping the family. And so that's when having access to legal counsel becomes critical. And this happens in a variety of other social conditions, which I won't go through right now. So in 1993 at Boston Medical Center, the chairman of the pediatrics department hired a lawyer. And he said, I don't want you to work for me, and I don't want you to work for the doctors in the department. I actually want you to work for the families. And I want you to help the families address their unmet legal needs, which we know are going to have housing benefits. And this has led to the the growth of medical legal partnerships, which have actually now grown across the country. There are several here in the state of Pennsylvania. There are 3 core components, which I'll go through really quickly, and then I'll go through an example of how we've addressed hunger using these 3 core components. So the first is the legal assistance, and what I was telling you about, of sort of direct client representation, or in some cases legal information, which has been really key to helping the family with their problems. The second is the transformation of practice. So bringing the lawyers into the medical system and giving them giving the docs access to the legal system has helped create cross-practice changes. So in one case, this allows lawyers often to have a more preventive stance rather than doing eviction case after eviction case after eviction case in our housing unit. They're able actually to take on some cases a little bit farther up the road through early identification. On the medical side, by having backup in terms of helping families with their unmet legal needs, we are then able actually to change the way that we're practicing. We're actually able to ask about these needs. So I think maybe the reason why only 17% of patients said they'd been asked in the last year in that first slide was that what was the doctor going to do when the answer was positive? And finally, the goal of having these 2 groups work together and work systematically on a series of cases is to set us up for policy change. And in the case of hunger, you can see that this plays out in very direct ways, as I've talked about in legal systems. In health and legal transformation and in practices, I think we've been able to routinize hunger screening in our clinics and also do certain things like we were able to bring, in Massachusetts, the Department of Transitional Assistance is what administers our food stamps and TAFDC benefits. And we actually were able to, with the help of MLP, move a DTA outstation into the hospital so people can actually apply for food stamps when they're at the hospital. They don't need to make a separate visit. But I think some of the most exciting stuff has come from, again, the systematic review of cases has led to some really interesting policy changes, which we can talk a little bit more about. But in a review of 100 cases in the Boston area, it became very clear that cases coming out of a particular DTA office, so again, that particular agency that's administering food stamps, we're having a much higher denial rate than applications being processed in other offices. And through careful review with other legal agencies, this actually led to a staff change at the office, which, glamorous or not, I think is actually a really powerful policy change.
Thank you. Okay. And Mr. Stein, do you believe that child hunger advocacy is especially rife for these cross-sector collaborations? And what lessons can be drawn for it for advocates in other areas as well?
Okay, first a confession. I'm a graduate of the law school, class of '67, and I've worked at community legal services for all the years since. Instead of a life sentence, I guess you'd call it, maybe. No probation, no parole. This session has been deemed the ethics session, so we're going to, I may be mentioning ethics a little bit mainly because there's so little time tossing out questions at a sort of macro level and then bringing it to the law school and then bringing it into some food advocacy we did over the years. At a macro level, I think you have to ask, ethically, how is this country allowing childhood hunger, childhood poverty to continue without even a game plan, a national policy to eradicate childhood hunger? President Obama, 2 months before the election, said that he would press for a anti-hunger policy that would end childhood hunger by 2015. That has not happened. There's no policy, there's no plan. The Child Nutrition Act that he sought $10 billion for over 10 years of additional money was watered down to less than half of that, the law that was passed recently, and even a large chunk of that money that was allocated over 10 years was stolen from the food stamp program out of future food stamp increases. So although there were some solid marginal gains and substantive gains in that Child Nutrition Act reauthorization, it was far away from really a goal and really embracing a goal or even a plan for ending childhood hunger. And I think that's the prime ethical question that one could ask of ourselves, ask of our national government. Bringing it down to this law school, we can ask ethically, where are the social justice courses at the law school? Where is the anti-poverty courses? Where are the anti-hunger courses? I'm told, because I don't often come here, that my friend David Super, when he taught here as a visiting professor in 2004, taught a law and poverty course. That was 7 years ago. Poverty hasn't disappeared. It's increased since that time, although it seems like here at the law school, law and poverty has disappeared. And if you go down a whole list of areas of problems low-income people, whether it's hunger, evictions, foreclosures, lack of health insurance, and there are many, many more, including issues of inequality, gender, race discrimination. Those courses don't appear to be regular core courses, either at 1L or other levels. And then you can also ask, where are the full-time faculty committed to teaching those courses? And I think those are ethical questions that have got to be asked of the law school. I'm pleased to hear that a number of law students have begun asking these in a more organized fashion. There are probably alumni outside of this school who would love to work with you on that, but I think part of the national problems we're talking about of hunger and poverty also are reflected in ethical challenges, if we want to use that term, here within the law school as to what courses are taught and what faculty is hired to teach those courses. Switching to, and that's a longer story, but the time is running out. And I'd be happy to talk about that after the session too with people. In terms of food, hunger advocacy, I think we've gotten a good understanding from the terrific people to my left that all of this is interrelated and requires a broad attack on many fronts. But when it comes to food and nutrition programs and public law or legal aid advocacy, you get into an area where this doesn't fit into the typical lawyer-client relations and case accretion that is the normal practice of lawyers. Mothers of kids who don't have a school breakfast program or are having difficulty getting a free lunch or, as I'll mention a few years ago, have no school lunchroom facility, as a dozen Philadelphia high schools had, affecting 35,000 kids. They totally shut down all their lunchroom facilities for a number of years in Philadelphia. Those issues are not the issues that people walk into a legal aid lawyer office or a public interest law office and say, this is a legal problem, I need help on this. So it puts an added obligation on lawyers, and a difficult one too, because there are lots of issues that don't walk in the door, as to what, reaching out to find and researching these things, finding legal handles, and establishing some, because you don't have that individual client readily there, although you can find them, I think, establishing a legitimacy and accountability for that kind of initiative. And that's a challenge, I think, particularly in these areas of these less visible areas of poverty, like lead poisoning, childhood lead poisoning, another issue I've worked on over the years, which are not, a typical legal issue of eviction or loss of food stamps or welfare, enormously important issues, but a different order of issue. And my school meals advocacy that I've done at Community Legal Services has focused on a number of problems. I mentioned one, the closing down of a dozen lunchroom facilities, and done very quietly for other reasons, just disciplinary reasons, use of space, whatever. That led to a drafting of a civil rights complaint, which we leaked to the school administrators, who got it to the superintendent, and within a matter of weeks, the decision was made to reopen all those facilities rather than face a rather embarrassing civil rights Title VI action in federal court. A somewhat larger issue that a wonderful Penn Law student who was working with me, Paul Morini, and I kind of put together, and there's a paper in the Clearinghouse Review article from '91 that we had published around that, was the fact that the whole school meal system is based on sort of virtually an 18th century notion of paper and paper applications, with an overlay of a 500-year-old Elizabethan poor law, sense of means testing and interrogating people about their income and resources. And we discovered an amendment in the National School Lunch Act in '89, Paperwork Reduction Act, wonderful name, that allowed a school district to avoid paper applications entirely and simply establish eligibility of all children in an entire school for free lunches and free breakfasts. And working with some people at Temple University, some statistics people, doing pretty basic stuff of surveying income throughout the city, it led, with a lot of other intermediary steps, to the school district adopting for 200 schools of the 300 in Philadelphia in around 1991, blanketing those schools. We called it universal feeding or universal meals, so that no family in that in those schools for the last 20 years now have had to, submit or forget to submit or whatever a paper application establishing their eligibility for school meals. There's a lot later history of the efforts of the Bush administration in the last months to kill the program after big cities like LA and New York lobbied to get the program established there. The Bush people responded by saying, well, let's get rid of Philadelphia's model. That will get rid of the pressure on us. And there's a further history of how the universal feeding, as we've called it, sort of lived on, although in a marginal way, in the new Child Nutrition Act. So let me stop there, I think, before they really turn off the microphone.
Thank you very much. So at this point, I wanted to ask the panelists to see if they had any questions for each other. You guys have all said very interesting parts of the story, and I'm sure we would love to hear more dialogue along those lines. At the same time, there are index cards. If you have questions, please feel free to put them on the index cards. I will be alternating between the index cards and actually using the microphones as well, so you should probably raise your hand and let one of the microphone holders know that you are interested in asking a question. So does anybody want to start first?
I think I would ask Dr. Conroy, the idea of a non-lawyer office having a legal advocacy capacity is a really very enticing one, because there are obviously health clinics and hospitals, there are other social agencies, housing authorities, that could also embrace a kind of legal advocacy component from clients. I'm wondering what your assessment of it is, given that you really have to talk also about the resources, the staffing of experienced people, the expertise of that kind of operation, and just, is this an efficacious model to be expanded?
Right. Well, so and one of the things I did not allude to, and I think it's worth saying, is that in the medical world, not to quote this idea that, well, the poor can just go to the emergency room, right? I mean, that's not the idea I'm putting out there. But in fact, if you are close enough to a medical facility in this country, generally people can get some kind of care in an emergency. Again, we won't talk about the finances of that. But as a medical person, it's really shocking to realize that the legal services available to low-income people are just so, the pressure on them is so high, and they are so few. There's just really there's no reciprocity between the two systems. So obviously, whenever you say, that's great, let's shift some of the lawyers over here, you want to make sure that that's actually, you're doing a really good job with that, and you're not taking away resources. You want to be adding resources. At the same time, doctors and other medical professionals are never going to be lawyers, right? And that's actually not going to help the system if we're running around giving people bad advice. And so I think we see our job as having sort of three different answers to that conundrum. One is, I think there is a certain amount of legal training you can give, or a certain amount of training on how the system works that you can give medical professionals, so docs, NPs, nurses, social workers, that actually helps them give better advice to families, and that literally may fill an information void. Things like, actually, you can apply for food stamps for your citizen children without revealing your own status. Things that you want to make sure you've trained people on well, but don't actually require necessarily, and please push back on this, if the information is good, I think that actually the information gap can be helpful. Filling the information gap can actually make a difference. The second thing is that often what we do, in Boston we have a very unique model where we actually have a small in-house legal team that works with our patients. And I should say the team is actually at Boston Medical Center. I'm at Children's Hospital Boston, and that team at Boston Medical Center works with docs all across the city. So it's in-house, but not always in our house. And they're dedicated to the medical legal partnership. Across the country, actually, the way the model usually works is that it's an existing legal services office that teams up with an existing clinic. And so in that sense, we're not actually adding lawyers to the picture. But I think what we're doing is trying to bring, again, some of that legal education into the healthcare system to take off some of the informational questions. The third thing we're doing in Boston, which I actually think is one of the things, and Yaya and I were talking about this a little bit before, is we've actually created a pro bono network for these cases, and we use our in-house legal team not only to do direct cases themselves, but to mentor pro bono partners. And the pro bono partnerships are very serious. The firms actually adopt a health center that they work with, and they get mentorship from, again, our in-house lawyers. Because clearly the person coming in from the firm, from the real estate section of the firm, isn't going to necessarily like have a whole bunch of recent experience in some of the conditions cases we're taking on, for example. But trying, again, to provide that mentorship to actually increase legal capacity. Is that getting at what you were? Okay. Okay. I have a question for both Dr. Super and Dr. Chilton. So we've said that if I heard you right, Dr. Super, we've said that the governmental response is not necessarily adequate. There's things that are lacking about it. Dr. Chilton, you've given one example of how to change the mandate, and I'm wondering if each of you could talk a little bit about what else you think it's going to take to change the mandate. I guess the question for Dr. Super is, what can we do in this political climate to really to help change that mandate? And then for Dr. Chilton, I was wondering if you could talk a little bit about watching some of the impact of bringing these photos and these collections of stories to people, and what those reactions have been like, and whether you've seen people have a kind of revelatory moment.
You're first. Yes, you first.
The simple and unglamorous fact is that the problem of hunger is a problem of resources. There is simply no way to cut SNAP without increasing hunger, and anyone that tells you otherwise is playing you for being very foolish. We are hearing a great deal of talk these days about the need to cut the deficit while preserving tax cuts for the very rich, and these sort of massive spending cuts used to be what was called cooling off the economy. This economy doesn't strike me as needing to be cooled off, but I'm no economist. If this round of budget cuts includes cuts to food stamps, as Jonathan mentioned, we've already been cannibalizing the food stamp program as a source of funds to support various other initiatives, some of them good initiatives, but still having impacts, and that's going to move us backwards. That's going to increase hunger. What we need to do is to get rid of some of the very unreasonable rules that SNAP still has that deny assistance to people without regard to need, rules that deny assistance to immigrants in this country, rules that deny assistance in a number of states to people who've had involvements with the law over drugs in the past, rules that say that for certain categories, and I'm not going to take the time to spell out who, so don't think this is most people, but for some people, that if they can't find a job within 90 days, that they will be thrown off of SNAP, where one with limited skills can be counted on to find a job in 90 days in this economy is beyond me. We need to get rid of those rules and make eligibility for benefits based solely on need, and we need to fund the administration of the program well enough so that when eligible people come forward that they get served. And we need to above all, not step backwards by cutting back on the program.
I'll respond to the question about what's been the reaction to the Witnesses to Hunger program and how we're going to be able to break through. I think that the reaction to Witnesses, when Witnesses operates on multiple levels, we work with the press to make sure that stories get printed and that are moving and touching, and we will be covered by Parents Magazine, and we've been covered by Good Morning America CBS. Is to raise awareness. But it's not just awareness intellectually, it's to raise a sense of compassion and empathy with people who are suffering, and a sense of a shared and common humanity. So in general, I'd say that people have been very responsive. The people who showed up to the exhibit are very thankful that they actually have a safe place in where they can actually meet a person who is poor and not feel threatened, not feel sorry for them, but feel actually empowered that they've heard the story. In the same way, the women who participate in Witnesses are very excited to be able to talk to people who may be wealthy but also caring. So there's good breakdown of barriers, et cetera. But we're only at the beginning. I think that we've been able to touch some people in Philadelphia, and it's thanks to the stories that Alfred Lubrano covered in the Philadelphia Inquirer recently that we finally got the attention of the mayor, although we've been pretty much knocking on his door every other day. It took the stories in the Inquirer for him to actually respond and start saying, okay, well, now we need to have a citywide plan, which is great. But, you know, we've been working on the mayor's office for, Jonathan, you've been working on it for, I don't know, forever. Mm-hmm. And it's only been 6 years since I've been working on it, and it's the first time. So it takes a lot of time and a lot of twisting, and this is just really the beginning. There's a lot of negative response to witnesses on both sides of the fence. First of all, there's a sense that the women who speak out and who are extremely articulate are black and Latina. And then people say, well, why are you only have black and Latina women? And we do have white women. There just happens to be less of them. It's actually quite indicative of our city. But, you know, the issues of race and racism are really prominent in the issue of hunger and poverty. And we do not do a good job of addressing it. And just look at us on the panel. And look at us in the audience. Our diversity, we are not a diverse crowd of people. And we need to do more to ensure the participation of the people, again, who know poverty and hunger firsthand in the national dialogue. And it's not going to be on the backs of 42 women from Philadelphia. It's got to be hundreds and thousands of people being able to speak up. And so we have to create infrastructure that allows for those families who normally would have no platform in order to speak, in order to participate in that national dialogue. We have to start changing our infrastructure to allow that type of participation. True, civic, democratic participation, right? In this country, we do not have a democracy. As long as we have hunger, we have no democracy. So I feel like all of us have to do more to be able to share our resources with people who are low income and ensure that they have an equal voice and have equal participation. And that takes a lot of money and a lot of time and a lot of emotional and intellectual effort.
Thank you. Now I'm going to open it up to some questions from the audience, but since I'm the moderator, I get to go first. I'd like for somebody to talk a little bit more about the transformation from direct services to this cross-sector collaboration and what sort of ethical issues have come up and what lessons can be learned from people not necessarily working in hunger, but hoping to work in cross-sector collaborations. You can answer fairly quickly if you prefer.
Well, I'll just say fascinating ethical issues come up when doctors and lawyers get together. So again, I was sort of saying to Yaya earlier, it's so great to work with the lawyers I work with, because if I think that I'm a fierce advocate, I then look at these people and I'm like, I'm a wimp, right? I mean, we have so much that we share around what we're hoping for families. But what's really interesting is, so in the medical world, we have HIPAA, and so we wouldn't talk to people we wouldn't talk about a case in an elevator, and we wouldn't talk about a case with someone who doesn't work at our medical facility. Barring all those places, we'll talk about anyone and we'll tell the whole story, and it's fascinating, and you share all the details, and you get good advice, and you share a lot of stuff. And then you start talking to your legal provider, and they're like, oh, that's really interesting. And they say nothing back, right? Because all of these sort of confidentiality rules are actually really different. So it's been fascinating for me to learn a little bit about what it's like to be on a team with someone who actually represents a different aspect of the patient's interests. They call them a client, obviously, but the client's interests. So that will come down on the fact that I'm actually the child's doctor, and I work a lot with the parents, and I always think that I'm the parent's doctor, but actually I'm not. And usually the lawyer is actually the parent's lawyer, and occasionally issues arise around that. Again, the confidentiality rules arise. We have interesting issues around them accessing the medical records, and it turns out when I talk to folks who run medical legal partnerships at other hospitals, no two general counsels at any of the hospitals we work at actually have made the same policies vis-a-vis lawyers being in the medical record. So there's no actual standing policy on that. So we've come across a lot of interesting some of it is very just transactional and sort of about the processes. I haven't told you a fascinating story, but for me it's been really interesting to realize that these two groups who have so much in common with their aims come across these barriers all the time. That helps.
That helps. Thank you.
My sense is that both doctors and healthcare providers face some similar trade-offs, which is you see individual people coming through your door with problems that you can solve for that individual, and there's a strong and entirely proper temptation to want to throw all of one's energy into that. And one has to balance that that human response. If we stop responding as people, then we're part of the problem, with the recognition that we can't possibly solve the problems of all the individuals that would like to come through our doors or would come through our doors if they knew we were there, and how one balances that individual work with dealing with the systemic problems such as the ones we've been discussing here.
And I would just love Dr. Chilton to comment on that from the public health perspective, because I think that's also, even from doctors to public health workers. I'm studying for a public health degree at the moment, but first and foremost, I'm a doctor. And so I actually, even in times where I feel like the systemic work might make more impact, actually, at the end of the day, that's not my job. My job is to work with the patient who's in front of me. I'm their doctor. And so occasionally I am actually torn with that I say, I could maybe make more difference by backing off and spending my time elsewhere, but actually that's not my job. I have to do my patient's work first. And I think that's one place where medicine and public health sometimes bump into each other.
Mm-hmm. You're right. I don't think I have much intelligent things to say about public health collaborations in law that haven't already been said here. But I think, unfortunately, in public health, we think about public health law, we think about Medicaid and access to health care, and not enough about the social determinants of public health and how lawyers can work on the social determinants issues. So it's, we're working on it, and there are lots of my colleagues have good grant proposals to start doing it, but it's, we are in our infancy, frankly.
All right, thank you. The next question from the audience is, can you discuss the nutritional standards for school lunches? The panel is also about the fight for healthy food, after all.
Doctor.
I really cannot. I'm not an expert on the nutrition of school lunches, and I would love for someone who's worked directly on that issue to comment. I think that we share the notion that you share, which is that school lunches generally do not provide the most balanced offerings to children, and that's a complicated story also in terms of what children actually will eat. So I would actually really love to turn that back to you and talk about if you could, and talk a little bit about some of the budgetary pressure there, or any work that's been done to.
Yeah, I mean, there's a lot going on, and and a lot of the work we do is rather specialized. I mean, we focused more on access, entitlement, benefit, eligibility issues, because that's, I think, our forte in legal services and what we do best. And we see there are other advocates working on nutrition issues that often neglect, this area that few people work on. But there's a wonderful book on the history, politics, policies of the school meals program by a Hunter College sociologist named Janet Poppendick called Free Lunch or Free Meals, that goes into the host of these issues, such as the need to use commodities which are often not the best for lunches. The amount of reimbursement, you probably have, well less than $1 a meal available because of reimbursements from the federal government, which directly impact. So our food services people here in Philadelphia and other places would say impact on using fresh foods, which are more expensive. So probably the bulk of meals that are served to well over 100,000 children in Philadelphia are trucked in from a Brooklyn sort of food processing place that can package things and use commodities well, efficiently, and meet the cost restrictions of school meals as served here. So it's a very challenging area. There are some extraordinary potential for economic and community development projects of using local fresh food. There's a bit of farm-to-school programs, some piloting of that being done right now in Philadelphia. But it's a major problem. And sometimes, the kind of knocking of school meals really goes a bit too far in denigrating them, since they may be the only decent meals a kid gets. and they do meet federal nutrition requirements, and but you know, it's certainly one piece of this is nutrition content, quality, as well as eligibility, access issues.
If I could just add two more things to that, which has already been covered, but just more specifics. The nutrition standards right now are open for comment. The USDA has now, in the child nutrition reauthorization, the USDA has said that they want to follow the new standards from the Institute of Medicine. So if you go to the USDA website and you have some strong feelings about the nutritional standards of school lunch and school breakfast, you can actually put in some of your ideas, and you can actually look at all of the requirements in wonderful, luscious detail. In the child nutrition reauthorization, there were some increases to supposedly improve the quality of school breakfast and lunch, or school lunch, and that increase is an entire 6 cents per child. I think it's going to be rather impossible to improve school lunch very much. And actually, I have one last thing: is that the quality of food and the access to food is a constant struggle in the anti-hunger and the food advocacy world, because the food advocates are all thinking about the quality. Is it healthy? Is it good? What about competitive foods? And they do it without thinking about access. The people who are so concerned about access rarely think about quality, and we have to stop that kind of divide. Because it's, from my perspective, food insecurity is, or from most of our perspectives really, who do research, who understand that it's not just about access, it's also about quality. And I guarantee none of you would agree that, you know, if you think about a food pantry that has Pepsi and Tasty Cakes, because that's what they happen to get that donation this week, is adequate and appropriate to give to a hungry family because they would have no food otherwise. It's completely inappropriate to think that way. In the same way, to talk about school breakfast, to not dwell on the sugary muffins and the junk that the children are fed through the school breakfast program at the same time that you're trying to increase access. It's an inadequate. We have to get smarter in the way that we advocate for these programs. We have to think about children not as just people that we want to push food into, but that need a quality of life and they need to have good health.
Can I also add on the interdisciplinary aspect? Okay. Mariana's point reminds me of Mariana's own contribution. I mean, any good advocacy, I think, legal advocacy, policy advocacy, has to be interdisciplinary. And when we made a recent school breakfast expansion push in Philadelphia, because essentially fewer than half the children getting a free lunch were getting a free breakfast. They were eligible for it. You know, they needed it, they were hungry, whatever, poor, but the enrollment was, you know, far different. And when we put together a push which included a presentation to the School Reform Commission, and Mariana did an extraordinary statement of connecting school breakfast with cognition and learning and performance of kids in the school, which I think really provided the science and the health aspect, which set a basis for the School Reform Commission, the superintendent really running with a major expansion of the breakfast program, setting goals on principles, having a principles report card that otherwise would show latenesses in reading scores and arithmetic and all this stuff. It now has a place for what is the percentage of kids enrolled in the breakfast program. So every principal in Philadelphia just 1 year old is now supposedly being judged on the basis of their school breakfast performance. So, you know, there's fertile room for advocacy, and especially interdisciplinary advocacy.
That's great. All right, Kendra, do you have a question?
First, I just want to thank all of you for coming, and I have a question mostly for Jonathan, but for all of the panelists. I know a lot of us are law students. I'm a law student, and I'm wondering how I can use my law school experience or how law school might prepare me for advocacy in this area.
Okay, you know, I think connecting with as much out of law school work is really important, whether it's pro bono volunteer work, whether it's externships, and with other public interest operations, and it could be with nonprofit organizations, since there's some bang-up ones in this city that aren't, you know, traditional public interest lawyer places. So I think maximizing your clinic experience, your external work, volunteer work, to the extent you can do that, I think would be great. They're motivating, they're learning experiences, they build skills and connections for what you can do later, wherever you are. And we're always hopeful that wherever people are, whether it's whatever law firms, whatever, that this kind of work can be built in. And one small comment on Dr. Conboy's statement about, and I can understand, not only for doctors but other professionals, that the work is often very case-oriented, but I think the critical component for everyone, every professional, wherever you are, whatever you're doing, is having a vision of a systemic reform, of seeing broader problems than the one that's on your desk or walking in your door right there, and finding the time as best you can to really, work on systemic issues, hopefully with other people so you can increase the impact of them, but often using either the experience of the individual casework, the patients that one sees perhaps, or individual clients, and seeing patterns, practices, broader problems that really need impacting, because it will always be very few of you to do that kind of work, and we have to all be cognizant of doing it and doing it as collectively as we can.
Thank you. I've got a couple of questions about allies in this fight. I think Professor Super, you might be helpful in this one. Can food suppliers and distributors, i.e. U.S. agriculture and grocery stores, be an ally in efforts to combat child hunger, or is this too idealistic? My understanding is that the agricultural industry is heavily subsidized. I'd like to know what role this reality is being ignored in the policy debate. And thirdly, any comment on corporate entities that are only funding international and perhaps not domestic work?
Certainly on occasion the food industry has been important to the program. I think in getting the program set up, the farm interests were important in seeing food stamps as a consumer of their products. Since then, it's been a more complicated relationship. As you mentioned, we spend a great deal of money on farm subsidies, many of which go to some of the largest corporations in this country, and many of which are indeed multinational. Those programs, those subsidy programs, are competing with dollars, particularly with SNAP, but to a lesser extent with the child nutrition programs as well. And there have been a number of trade-offs over the years between them, where the agriculture committees are told to cut a certain amount of money, and the farm interests say cut it out of SNAP, and we try to say cut it out of the farm subsidies. And with the agriculture committees, we mostly lose on those. But I think there certainly are room for some partnerships there, and indeed, as international trade agreements make farm subsidies more problematic, that there's some export-oriented agribusiness that actually has supported shifting money out of farm subsidies, which are prescribed by those agreements, and into SNAP, which is entirely permissible.
Could I add some intrigue? Well, first of all, the official answer is, of course, everyone could be an ally in order to address child hunger. Everyone should be able to get involved, especially the corporations and the financial institutions that have so much money and so much leverage. They can actually contribute a lot. It's how they contribute is a little bit problematic. I just want to give you a little heads up on a current controversy that might arise for the next Farm Bill, and that is there's been a push by public health professionals to not allow people who are on food stamps to buy sugary drinks. In other words, Coke, Pepsi, etc. At the same time that announcement was made, the anti-hunger community, which some of the groups can respond very quickly, all allied themselves with the American Beverage Association. That's Coke and Pepsi, etc. Behind closed doors in order to make deals so that the anti-hunger crowd came down very hard in saying, no, there should be freedom of choice. This is about the basic right to choose whatever you want to. And if someone wants to have a party in their home to celebrate their first graders, their birthday, and they need to have Coca-Cola, they should be able to buy Coke. And then at the same time, you have public health people and the people who want to blame the poor for the supposedly poor choices. It's a very problematic situation, and some of the most generous funders of the anti-hunger community are ConAgra. I don't know how much you all know about ConAgra, but I mean, you can go and look it up. And now the newest corporate entity that has joined the fight to end hunger is Walmart. $5 billion they are going to be giving over the next 5 years. And even some of our local partners are receiving some of that Walmart money in order to do some anti-hunger work, and it's very exciting. And there's even been an offer to the mayor to receive the Walmart money in order to hire that person to create a citywide plan. Very interesting. But if you think about Walmart, the best way that they could contribute to ending hunger in this country is to actually pay their workers a living wage in which it's not allowed to happen that a person should be receiving Medicaid and food stamps or any other kind of subsidy off of the government. And I would love to write an op-ed in which I call Walmart the ultimate welfare queen.
That's fabulous. All right, we've got one question out here, and then I'll have one more question, and then I think we'll end.
Hi, thank you guys so much for coming and speaking. I'm actually a social work student, and my question is that in light of the fact of the misperceptions regarding hunger, and especially the questions that you said the doctors don't ask their patients, how difficult was it to get a partnership started with the hospital?
That's great. So I think that there's this concept of outcome expectancy, which has been spoken about by folks who look at what it takes to change medical practice. And the concept is really simple. It's that you are more likely to take an action if you think that the outcome is going to be positive. So if the radiologist who's in the clinic that day is really good and you need an ultrasound, you're like, I'm going to get an answer. If the radiologist who's there that day isn't that good, you're not going to order that ultrasound, right? So you take actions based on what you think the outcome is going to be. And so I think that it's very easy to get doctors to ask questions about unmet needs that they know are there. It's not like anybody goes into the business where they're serving a population that's 70% Medicaid and doesn't like realize that these things are happening. And in fact, actually, I think those numbers slightly underrepresent. People may feel like their doctor didn't ask about it because they didn't actually do anything about it, but I think we're asking a little bit more. But I think a lot of the not asking comes from not feeling like you have the solution to provide. So when we sort of came in and said, can we do a training for you on food resources in the area? People were like, when, where, and how much do I have to pay? I'll be there. Like, the people are so ready for information on how to help their patients. So actually, I think that was very, I don't think that's been any trouble in getting doctors excited about the idea of having more resources for their patients. I think that the pushback is, I don't have time to do this well, and as a social work student, you can also understand this concept of, is this my job, right? And there's this really interesting trade-off that I think happens, and I think this will happen, I think anybody at any job could think about an application of this, where the higher the specialties you have at your fingertips, or sort of the more real experts you have at your fingertips, the less good you get at doing those things. So ironically, sometimes by bringing in more resources, we disempower docs to actually be the person who really knows how to do the advocacy. But that's a risk I'll take if we actually have, if at the end of the day, the patient client is getting what they need. But in general, hospitals have been very receptive, and hospitals have actually ponied up the money to pay for their part of the program, just as the legal aid offices have stepped up to say, we'll do this collaboration. So I think that they're getting benefits, and one of the ways they're getting benefits is some of the cases that we take, this isn't hunger related, but our SSI and other insurance cases where sometimes the back payments are enormously helpful to the hospital. So we've also been able to demonstrate this not only in the benefits to the hospital, not only in sort of a moralistic, how are we serving our patients kind of way, which obviously is the key part, but we've also been able to get hospitals sufficient funding by joining into a medical legal partnership.
I have two practical things. Children's Health Watch, we just recently published an article in Pediatrics about using a food insecurity screen. It's a 2-question item in which all doctors can actually use it in their clinics, and they can immediately find out whether someone is food insecure or not. And what would be the follow-up? Of course, making sure that person can get signed up for food stamps, which makes, you got to make sure the social workers are there. But one of the things we tried to do at HUP last summer, but were unsuccessful, was to try to get the times when the families are getting signed up for emergency Medicaid. They already have an agreement with the Department of Welfare in order to get that person emergency Medicaid. At the same time, they could be in that system and helping a person get access to food stamps. But we ran into some legal issues, and it turns out that HUP has a special agreement with DPW only for emergency Medicaid, so that they can get payment for that one-time emergency room visit. Next time that person comes back into the emergency room, they have to do another application for emergency Medicaid coverage. I challenge some of you students to get involved in this issue so that HUP can actually not only screen for food insecurity, but ensure that families are getting signed up for food stamps if they're eligible.
All right, great. I'm going to ask each panelist to do a one-sentence answer to my next question, which is a combination of a number of questions about the forefront of hunger advocacy. Where do you see where do you see your role in the forefront, the next transformation of hunger advocacy? And I'm going to list a couple of suggestions about things that are happening. Increasing access to SNAP benefits, the nutritional restrictions of WIC, putting that into the SNAP as well. A class action suit to solve the school-to-prison modality, and stripping people of various types of eligibility because of criminal convictions. I'm going to start with Mr. Stein.
I'm not sure.
One sentence.
It's over.
You have to do more. You have to do more than that, and do it holistically and on a multi-issue basis. Okay.
Okay.
Where I hope that my work will be is, as we've been talking about small policy changes that can impact a lot of people. So, for example, this is a run-on sentence. For example, just as Dr. Chilton was talking about, we've been able to get folks in Massachusetts when they're signing up for TAFDC or welfare to actually get the food stamp application done automatically as well. And so I think when you make small changes that are on a local, may feel like they're on a local level like that and are very, not very sexy, right? There was no legislation involved. I think you actually can really see how that impacts people's lives. And you can start to see the impact of that really fast, especially when you're a practitioner who's on the front lines. That was 7 sentences.
I think the most pivotal thing is to fight the major efforts that are going to be made in this year and next year to cut SNAP and other basic programs for low-income people. I would also, footnoting that one sentence, say that that although I understand the appeal of applying nutritional standards to SNAP, it's something that I fairly strongly oppose, and I'd never received a dime from agribusiness to the best of my knowledge, because the consequence of that is that if someone were to buy, first off, defining what foods are and are not permissible in a way that anyone can understand would be very difficult, and if someone were to buy a bottle of overly sweetened juice with their food stamps, they could literally be sent to jail. And although, and there are a number of states, on occasion this one, that have prosecuted people for very technical violations of SNAP rules, and I would hate to expand these technical SNAP rules to increase the risk of that.
I would say two things. I'm working on more participation. Why more participation? To ensure more accountability. And I think every day each of us should be writing to the White House to say, where is the national plan to end childhood hunger by 2015? All of us need to participate more. We need to be more civically engaged, and we need to be able to start holding our leaders more accountable than we have been in the past.
Thank you all panelists for your participation. This was a very fabulous panel. I just wanted to emphasize, I hope this is not the end of the conversation. I hope this is the beginning of the conversation. All the panelists will be sticking around a little bit, and they would love to hear your input and your questions. Thank you very much.